Psychiatry Residence Journal podcast. My name is Dr. Lindsay Lebin, and I'm the Deputy Editor and Podcast Editor for the Residence Journal. Our guest for today's show is Dr. Shapir Rosenberg, who is the Senior Deputy Editor for the Residence Journal. Born and raised in Denver, Colorado, Shapir studied philosophy and religious studies at the University of Pennsylvania. He's currently a psychiatry resident at the University of Maryland. He has a passion for end-of-life care, teaching, and the medical humanities. I'm thrilled that he's joining the show today to discuss palliative care, so thanks so much for being with us, Shapir.
I'm delighted to be here, Lindsay. Thank you.
Awesome. So why don't we start with some basics? Can you tell us a little bit about what palliative care is for those who are not familiar with it?
Yes, very briefly, I like to think of palliative care as whole person care in the setting of life-limiting or life-altering illness. So it gives attention to suffering in multiple domains, physical, but not only physical, spiritual, existential, psychological pain, and gives attention to it via multiple modalities and via often a multidisciplinary team, including physicians, nurses, chaplains, social workers, and the like. It can be applicable in the terminal setting when a patient is facing imminent or near imminent death, as well as someone who receives a new diagnosis that, though not immediately leading to death, nevertheless is likely to alter the life expectancy of that person. In the interest of time, I would also refer people, rather than elaborating on it further now, to the World Health Organization website, which contains definition that I myself often refer to of both palliative care for adults as well as the pediatric definition of it.
So it sounds like palliative care is really focused on managing serious illness, potentially even terminal illness, from a very holistic perspective.
Indeed. And an example of that would be, it seems, although other physicians can certainly do it and other clinicians, it's often within the realm of palliative providers to inquire of things like, what matters most to you? And how do you wish to remain time, however long that time is, and within the constraints of what is feasible given a certain kind of illness. I should also add, palliative care regards the bereavement period, namely the time after a patient's death, as also within its domain. I think that might be unique to it as a specialty outside of other specialties within medicine, where certainly, again, in the immediate period after a patient's death, there's support provided to family. But for many months after that, I've seen up to 13 months and beyond.
So it's not really even just caring for the patient, but caring for the patient and their family, kind of even long-term after the patient has died.
Absolutely. And to that point, I would simply add that palliative care, like some other domains of medicine, including family medicine, pediatrics, certainly has a recognition that the patient is part of a larger structure, a family structure, which both experiences the patient's illness as well as impacts and informs how the patient experiences their illness. So the patient is part of that, and the family, so both parties, the patient and family members, experience illness, and palliative care gives attention to that, again, both during the patient's lifetime as well as after their death.
I'm wondering if you can tell us a little bit about what drew you to palliative care.
Absolutely. I suppose most fundamentally, although I wasn't privy to it and didn't have the insight to it at the time, my mother's diagnosis and death from breast cancer, when I was young, the early driving force. She was diagnosed with inflammatory breast cancer when I was 11 and died after about a year and a half of treatments, including chemotherapy, radiation, and mastectomy, when I was 12, soon after I graduated from 6th grade. And unbeknownst to me, that early exposure, frankly, as someone once put it to me, being with a dying person, living with a dying person, set me on a path to doctoring and to wanting to care for those also experiencing impending loss.
So I'm wondering, how has your past experience shaped your approach to doctoring and to palliative care?
Well, what comes to mind, frankly, is wanting to provide for others that which was not in place for my mom and I. So when she died, the hospice and palliative movement was maybe just gaining traction or in the early stages of gaining traction in America. A palliative team was not involved with her care in the hospital. Hospice was not involved when she died. She died on the oncology unit, and there was little support for me. I never recall a physician or any kind of team member, be it social worker or therapist, speaking with me or helping to prepare me. And so in many ways, I've wanted to, I've certainly seen how loss and in some cases not being given the opportunity to say goodbye can inform a life and makes grieving hard. And so I've wanted to provide for others, both those experiencing illness, those reflecting on and facing their own deaths, as well as surviving family members, be they young children, be they elderly spouses, whomever, an opportunity that I wasn't given.
No, that's really touching and incredible that, you were able to take something that sounds like it was incredibly painful and challenging and transform that pain into something that is incredibly valuable and helpful to so many other people.
Thank you.
Yeah.
And Lindsay, if I might add, I'd be remiss in mentioning that later on, years later, after my mother's death, I came to see in the end-of-life setting a unique space where so many of my interests and I'll claim abilities come together. I was a philosophy major, and so the existential dilemmas and angst about who we are, what matters, and what matters when time is limited certainly surface in the setting of terminal illness. So the existential, spiritual, ethical questions, as well as the biology, frankly, of humans and the pathology that often leads to death, all seem to come together in the end-of-life space. And I felt uniquely suited for it because of my early experience with my mom, and drawn to it. So I would quite simply say it appealed to my heart, my soul, and my mind.
Yeah, I mean, it really seems like for a number of reasons that it's truly a calling for you, as I think it is for a lot of people that work in palliative care.
Indeed, indeed.
One thing that I'm wondering is, given your own experiences with kind of navigating your mother's end-of-life care, is how you've been able to manage the emotional burden of palliative care clinical work. I think a lot of people do consider it to be particularly emotionally taxing because you're dealing with families and patients in acute grief and you're guiding them through these kind of existential life and death situations. So I'm just wondering if you can tell us a little bit about how you're navigating that.
Yeah, it's a wonderful question, Lindsay, and I'm delighted that you ask. In general, because self-care and provider wellness is being given a lot of attention and thought these days, and in particular in the palliative care space. I'm not sure that I've done it well, frankly.
What do you mean by that?
So I'll provide an answer. Well, I'll answer, but I think only of late have I even come to see there are ways that I could have and certainly hope to do it better. I guess I'd begin by saying I've always felt that my inner reserves run quite deep, and be it in my own private time and moments of self-reflection, whether at home, whether reading, whether running, that I've managed to process so much of the experiences of witness suffering on my own or with others. And I would be negligent if I didn't mention a mentor of mine who I met years ago before I started medical school, who happens to be when I met him at the time, he was a hospice physician in Israel, who has been mentor and confidant to me in helping to process the experiences, not only in end of life and not only in palliative care, but across any of the hospital or clinic venues where people are experiencing illness and pain and suffering. And So I suppose I'm describing two things. One is a depth of inner reserve, as I might call it. Item two might be having close confidant or mentor with whom to share and process the experiences. And three, it seems to me, though I have not myself experienced it, invaluable to have process groups at all levels of training, be it medical students, residents, fellows, and even faculty attendings, to discuss the emotional toll that caregiving takes. Having mentioned a moment ago that I'm not sure that I've done it well, I just thought to elaborate on that for a moment. In my third year, which was my most recent year in my psychiatry residency program, I started a general cancer therapy group at my hospital, and it was every Tuesday in the afternoon, and I looked forward to Tuesdays. Quite frankly, it was a highlight of my year. But by Tuesday evening, every Tuesday evening, I came to notice just how exhausted I was. And the exhaustion was more than a physical variety. It was a real emotional exhaustion. I strove to be fully present with the patients in my group every Tuesday afternoon. And this was sometimes the group consisted of members who were very, very sick and struggling with a wide variety of issues, be it physical pain, be it existential pain, be it complicated and difficult family dynamics. And I think I didn't realize until really the end of the year just how emotionally hard that can be for a provider to be with and to bear witness to.
Once you noticed that in yourself, how did you
I think I'm
how did you deal
still
with it?
early in learning how to. I've always felt strongly in the benefit of process groups. I happen to be applying now for a hospice and palliative medicine fellowship, and I intend to look for and inquire at places where I'm interviewing if they in fact have or what they have as regards support for the caregivers, be it on a weekly or some other kind of basis to process the experience. I should also add Schwartz rounds, which is something that I've been involved with for over a year at my hospital, is also a wonderful modality on kind of a larger scale to process the emotional challenge of healthcare provision in the modern era. I'll spare you all the history of Schwartz rounds, but it came out of the Schwartz Center in Boston and is now a sort of international phenomenon that provides a roughly once a month venue for caregivers to come together up and down the hierarchy, if you will, and across specialties to discuss the emotional dimensions of caregiving. And I've come to be very involved with it at my hospital and to believe deeply in its power.
We have Schwartz rounds here at the University of Washington, and I've heard excellent things about the people who have attended them. I have unfortunately not been able to attend, but yeah, I hear they're incredibly powerful and healing for many of the participants and the audience in general.
Indeed, I'm delighted that you've even heard of it. I would strongly encourage you and anyone listening to this podcast to go, particularly physicians. There can be sometimes the experience of preaching to the choir at Schwartz rounds, and it's sometimes the very people who don't attend who might most benefit. So yes, if you're listening and have Schwartz rounds anywhere near you, try one.
Yeah, agreed. I'm gonna take your advice on that, Shapir. I need to get to one. I'm wondering, you're applying to palliative care fellowship. I anticipate that you'll get into a fellowship. Do you envision working as a palliative care physician for your career?
Yeah, and it's an interesting question. Thanks for asking it. I'll answer both for myself, and I think it's particularly interesting because I don't know how many people are aware that, particularly psychiatric trainees, be they med students envisioning a career in psychiatry or even psychiatric residents or fellows themselves, how many are aware that one can do a hospice and palliative fellowship from psychiatry? And the fact is that one can do it from one of, if I'm not mistaken, 10 different residency specialties, and psychiatry being one of them. So it is a field that does accept psychiatry applicants. We're small in number, but growing, I hope. As regards my future career plans, it's hard to say. I do envision devoting most of my time to hospice and palliative care. I don't know that I would ever be an inpatient psychiatry attending, for instance. I don't know if I would be an outpatient psychiatrist, though I'd like to leave open the possibility of perhaps a small therapy practice on the side. I would like to, and in part informed by my experience with the cancer group that I facilitated this year, I would love to be involved in creating, facilitating more such groups in whatever setting I end up, be it for cancer patients or other kinds of patients with serious illness. And to a very timely question of what I might do within the palliative care realm, sometimes palliative care is, or at least its practitioners, are divided into those who practice on inpatient palliative care consult teams, those who practice in hospice settings, be it inpatient hospice, home hospice, nursing home hospice, or the like, or those who do outpatient palliative care. And to that question, I don't yet know. I'm quite drawn to working. I'm quite drawn to working with those who are dying.
I'm curious to get your thoughts on why a lot of people who do psychiatry residency don't necessarily immediately think of palliative care as an option. I mean, it seems like it's kind of one of our less popular fellowships. What are your thoughts about maybe why that is?
I can't say how popular it is, although many people do often shy away from this kind of work. From a numbers standpoint, it actually has, and I was looking at NRMP match data just recently, there are more hospice and palliative fellowship programs nationwide and more spots than there are psychosomatic medicine programs or spots. And it's about on par with the number of programs and positions for child and adolescent psychiatry. So it's become quite an established subspecialty, although perhaps less known within psychiatry departments. I couldn't quite speak to why people are drawn less to it at present. I would argue, though, that those who have an interest in, again, it's sort of two words for the same specialty, namely psychosomatic medicine or consult liaison psychiatry, those who are considering fellowship or careers in that realm might want to give palliative care a look. Sometimes the cases and the issues that are dealt with in the hospital that trigger a consult liaison psychiatry consult are very similar to those that the palliative medicine team encounters.
Yeah, no, that makes a lot of sense, that there is this fair amount of overlap between those two subspecialties. Shapir, as we wrap up our interview, I'm wondering if I can ask you just a few last questions. One is, what do you think psychiatrists can learn from the palliative care model?
Yeah, well, thanks for asking. That's a very interesting question that I've given some thought to, especially in the past year or so. One example comes to mind, and that is, I think psychiatrists can overlook the devastating nature of some psychiatric illness for the patient and their family and their lives. And much as, be they protocols or intuition drives, breaking bad news conversations, or ongoing goals of care conversations in the medical sphere, so too I think psychiatrists could learn that certain psychiatric illness can be just as devastating, life-altering, potentially life-limiting. And so how we communicate about that, how we even think about it, let alone how we communicate it, but how we as providers think about it, how we communicate that to patients and families, and how we help patients and families cope with and through that, is a way in which psychiatry could learn from some of the approaches from palliative care. I want to make mention of one small story. I cared for a young man while on an inpatient service rotation. He had a long history of polysubstance use, including heroin, some other medical comorbidities. And I had one telephone conversation with his mother prior to his discharge from the hospital. And I can't quite say what motivated me to say it, And I used a word that psychiatrists seem rarely to use, namely the D word, death. But I cautioned her that her son was at high risk of death.
Hmm.
He overdosed in what was deemed to be an unintentional overdose within 24 hours after discharge, and he died. And his mother called me to inform me of that. And when she did, in addition to a funeral, to thank me for helping care for him, she thanked me for preparing her. And she specifically remembered our conversation and the very direct way in which I expressed concern that his life was in danger. And so I think there is an approach with respect to not only at time of diagnosis, but through illness course and in certain very severe pathologies where psychiatrists can take from the palliative model, where a direct and thought out and compassionate way of talking in quite real terms with patients and their families about what might come.
That makes perfect sense. It seems like there's some combination of like the transparency of the communication, but like combined with this compassionate humanism that really is helpful in the palliative care model, and we likely should be applying it more to many of our chronically mentally ill individuals that we work with in psychiatry. I feel like we have a lot to learn from palliative care. And so, Shapir, to wrap things up, I'm wondering if you can tell us just briefly what you feel the most challenging aspect of palliative care is and what the most rewarding aspect of it is.
Oh boy, two hard questions. I think the hardest part for me is the goodbyes, both bearing witness to goodbyes as well as offering goodbyes myself. There often is a moment in transitioning, can be an extended moment, but the moment comes in transitioning from a rather conscious state to sometimes when a patient is rendered unconscious and never to become awake or fully awake again. And helping patients and families and providers ourselves to say goodbye, to make last expressions sometimes for families and patients of love, of forgiveness, and the like, before they're unable to do so. Those are certainly meaningful moments, but also quite challenging. As regards the most rewarding, that's easy. It's the relationships. Recently, I attended what was, I guess you could call a pediatric bereavement panel, where a small group of parents, all of whom had lost children, and sometimes the children were infants, and in one case, he was a teenager, as I recall, spoke about their experience of palliative care and in the final stages of hospice care to a team of providers, including new incoming hospice and palliative fellows. And one father said, "You should know," I'm paraphrasing here, "you should know that you all are doing something that matters." He told a story of a relative of his who, young boy, broke his ankle or his wrist and went to the ER, and the orthopedic surgeon put on a cast, and home he went. And no one could quite remember the name of the physician. The care was technically competent and so good enough. But by contrast, this father expressed the sentiment that the kind of care and that is given by a physician or any kind of clinician in the end-of-life space is unique in that, as he put, they are welcomed into their families. They become part of families and families' lives and families' stories, both during the time of the patient's life as well as after their death. And so the relationships, the belief that this is indeed a space where things matter is the most rewarding aspect of it for me.
And that's so well said and beautifully stated. And thank you, Shapir, for spending past half an hour or so speaking with me about palliative care.
Well, thank you so much, Lindsay, for inviting me and for all of your efforts with our journal and the podcasts, which we're all quite excited about. I would also recommend that I'll simply put in a plug for the Residence Journal, which as of August 1st, has posted the August issue, which is a hospice and palliative care theme issue with a number of works from folks around the country, residents, one fellow, one beautiful poem as well. So I would encourage people to download that PDF, give it a read. If you would like to get involved with the journal, for those listening, if you'd like to get involved with the journal, please write into us. We're always interested in reviewing manuscripts. And come the spring, we'll be looking for people to help us on the editorial board. There are lots of ways to get involved, whether you're a medical student, resident, or a fellow.
Yes, I agree with all of the above.
Thanks, Lindsay.
Please join us.
Okay, take care.
All right. Thanks, Shapir.